resuming, and I'd like to remind everyone 3 minutes. And we've got the stop clock because we have specific agendas for each of you that I know you'd like to share with all of us. So if you could keep your comments to 3 minutes, but I'll turn it over to Ms. Michelin to start with questions from the board.
So I think what we can do is we'll kind of go down the road. First go around, you can direct your questions to anyone on the panel or more than one on the panel, and then we'll maybe go do public comment and then come back again if there's additional questions from the board. So I'll start with Donna. Do you have any questions for anyone on the panel?
I have a general question, and any or all of you can answer it. On the individuals who require more intensive care, what is the follow-up with them?
I'll go. On our program, if there is follow-up care, the doctor will fill out a referral form, and we have done research in the area for other optometry clinics that may have an optometry component, so they can get the follow-up care, and they take this referral form with them from the doctor, and it has a signature as well.
Could you please identify yourself so that from the webcast?
I'm Gilbert Melgoza with VSP Vision Care.
Meredith Whiteside, UC Berkeley Optometry. In terms of follow-up care, so we would oftentimes, when we were going to nursing facilities, we would be there, every 4 weeks, 8 weeks, 4, 8 weeks. If follow-up care was needed sooner, honestly, what I would do is I would refer out to an outside provider, or we would reschedule to come back as needed. If I thought that we could handle it safely and it was something benign like dry eye or something like that, that's something that doesn't have to be, you don't have to have the care right away. But if it was something more serious, like we had inflammation in the eye that needs, pretty, care pretty immediate and then needs to be followed closely, that's best served by the local doctors. And we would I would contact them myself and then make the referral so that they had the records, and then I would confirm that they were seen, and oftentimes they would send me their notes.
And then another question again, any or all. On your, no, I'm gonna wait on it, thanks.
Anything else? You're good? Okay. Did anyone else from the panel want to address Ms. Brooks' comments?
Yeah, Jeremy Bornstein from 2020 Onsite. So when patients are referred, so there's sort of two different types of referrals. One is more community-based patients, like a student or a community health, based patient. So in those situations,
Can you talk more into the mic? Thanks.
yeah, in those situations, we will coordinate with the referral partner that the patient has been referred to, and we'll also coordinate with the on-site contact for that individual location. In the case of a school nurse, we'll work with the school nurses to have the students reminded and the families reminded. We'll also work with the referral partners to understand whether the individual has been seen. In the case of community health centers, we actually will, as you know, you would need to share the medical records with the community health center for insurance and compliance with the actual care protocol. And so we would usually, the system is sort of very closed because we would share the records and they would sort of be really responsible for making sure the patient has been followed up with. And then we'll also coordinate with the health center to follow up as well. With sort of the more corporate, public-based demographic of the population, it's a similar type of model, but not quite as rigorous because we don't have that additional point of contact at the employer. We can't have the employer follow up, and so it's similar where we follow up with the referral partner and just understand which of the referred patients have gotten exams, and then we'll remind those patients.
Seth Shallett with Prevent Blindness. In our case, to your question, our population, our cohort are preschoolers aged 3 to 5. So if it's beyond, in our case, a simple refractive issue, we have a bilingual health educator. So after our optometrists make the diagnosis, the parents work with our bilingual health educator, and we work to make the proper referral for them to help them navigate that system. As I indicated earlier, we don't work with specific doctors, but we have a broad network of Medi-Cal accepting physicians in our area. Also with our partnership with UCSF Ophthalmology, depending upon the referral, we have made a number of referrals over the years where they have provided, in several cases, no-cost surgeries and care.
And I'll just add that for Vision to Learn, because of the scope of our operation, the volume, and the geographic, we're pretty spread out. We are eager to find partners in the various geographies that we serve that would be interested in being a consistent referral destination for the students that Vision to Learn serves. This would allow for more of the tracking of making sure that the students' eye issues were being addressed. And of course, this is on a location by location basis. Obviously, we have been in discussions with a couple of large providers in Los Angeles County. So I'm optimistic that we will be able to continue to improve that referral process and work to create the same kind of access to continued optometric or ophthalmologic care for kids that we're currently providing for glasses provision.
Any other comments from anyone on the panel? Any other additional questions? No? Okay. Mark?
Hi, this question is directed to the two professors on the panel. I have to admit, when I first came into the meeting, I was very concerned that that I understood that our state's laws and our regulations prohibited optometrists from doing house calls to homebound seniors. But if you can give me a reality check, is this actually a problem out in the real world? Are the seniors finding a way to get to an optometrist or ophthalmologist anyway and being able to solve their vision problems? Or is it a fact that even if this was permissible, no optometrist would be willing to do the house call anyway? Or is it that optometrists are doing it anyway, whether or not it's permitted or not permitted, and there's a realization that there's no enforcement risk, that the Board of Optometry is not going to go after you if you do a bunch of house calls? Or is it really is a problem and seniors are just at home suffering? This is particularly of interest to me because I know that the number one kind of cause for deterioration of a senior's life is and death is falling, breaking a hip or whatnot, and then and as one who wears progressive lenses, if you don't have the right kind of glasses, it's easier to fall. So, is this a problem? Are our regulations and state laws about mobile clinics, but I'm focusing on house calls right now, are they a problem?
In my opinion, yes. It is a huge problem. What got me thinking about it was I had an uncle, if you don't mind me relating a personal story. He had a stroke. And he was at home, and, as with chronic health conditions, it devastates your finances. And my cousin took him to the optometrist, and he was a big man. She lifted him and put him in the wheelchair, and then they got him in there, and he got into the private practice optometrist's office, and he had to go to the bathroom. It wasn't really wheelchair accessible, so she lifted him up, and he got upset, and he was heavy, and she was hurting her back, and chaos ensued. he got sick to his stomach because it was so stressful. And then finally, when they got him into the exam room, he was just exhausted. I mean, he was just slumped down in his chair. And honestly, the optometrist, I think, was a good doc, but he ended up just giving him his old glasses back because he couldn't cooperate at all. And that, there's something wrong with that, you know? I mean, this is somebody that deserves care, and it had a huge impact. And my cousin's comment, this was years before I went to optometry school, was, "Oh, we're never going to do that again. We're just gonna do without." I get calls from patients, or they say, "Oh, my mother's at home," you know, patients that are bedbound, and oftentimes this is, you know, people want to stay in their home. Everybody wants to stay in their home, but because they don't see well, you know, they're going to be falling, like you said, improper glasses. It's kind of this slide towards the nursing home, because oftentimes they can't stay at home because they can't see well enough, and there's a fall and they break their hip, and then there's a slide down towards, you know, being in a nursing care home. People who fall end up, I mean, it's kind of on the way to death. A fall for a senior is, you know, they don't bounce back. And so it does kind of slide them towards that nursing home, you know, and oftentimes when they end up there, they don't get out. They don't end up going back home. So in terms of your other question about, is this happening, in my view? If, like, are people doing house calls? People, the doctors that I talk to, they're not willing, you know, it's seen as like, oh, well, no, you can't just do that. I mean, part of what we had was, it was an educational program, but no, you just can't do that. So there's nowhere for them to go.
You can't do that because of our rules, or you can't do that because they don't want to do it?
No, because of respectfully, it seems like there's feeling that you can't do it because of the board of optometry.
Any other? Dr. Patel, did you want to answer?
Yeah, I actually don't have too much more to add to that. I completely agree. I think that's a really good question. The need is certainly there. Our university, to my knowledge, we don't participate in going to the nursing homes, but it's certainly something worth having a discussion for, because as you said, the need is certainly there.
Anyone else from the panel want to address the question? No? Do you have any other further questions? Okay. Ms. Garcia?
Thank you all. I've learned quite a bit. My question is, in new technology, and I've noticed that some of you are keeping up with that, bringing in new equipment, how do you see mobile clinics like years from now? Do you still think it's going to be there present? And along with that, because in what I do, I'm an optician, I see a lot of repeat visits too. So if I see a child 1 year, how are you following up where a year later they're still having that care? Is it through the mobile clinics? So I guess I have two questions on that.
I'll take that first. Seth Shallett, Prevent Blindness. It's a very unique and interesting question, because, you know, one constant in the 3 years that I've been running Prevent Blindness is that technology has really not only brought down the cost of certain services, but has really enabled access and the bringing down of barriers to proper medical care and follow-up, particularly vision care follow-up, that, you know, as little as 5 or 10 years ago would not have been cost-effective or technologically viable. So, for example, if you keep up with technology, there's no shortage of new visual acuity tests and apps meant for Android or iPhone-based operating systems, each purporting to have a little bit different secret sauce in terms of what they're able to do. Our view is that we want those to be enablers for what we do. We still feel at Prevent Blindness that there is no substitute for a full cyclopedic eye exam. But the way to provide ongoing after-exam support, to be able to follow up on compliance. Are a pair of glasses being worn? Are they actually on? Are they fitting well? Or are they ill-fitting and there is an opportunity to send a text message to the parent to say, take a look at Seth's glasses, or we can't tell that Seth has his glasses on and they're supposed to be worn between 9 a.m. and 5 p.m. So my only comment is I think technology is going to be an important point of both access enablement and bringing the cost down. And we're looking at ways that prevent blindness that we can optimize on that.
Hi, Jeremy Bornstein from 2020 Onsite. Yeah, so on the question related to sort of how are, in the case of students, how are they seen year to year? So with our school's programs, when a student signs a consent form, when the parents sign the consent form for care, that consent form is for the entire time that the student is at that school. And so once a student is in our program, the school nurses know that that student is eligible for an eye exam. So whenever we revisit that school the following year, that student will be placed into the program, slotted for an appointment. We check eligibility for insurance to the extent they're covered, and then to make sure they can get that care year over year. If they do switch schools, we have to seek an additional consent. Technology more broadly, I think, echo a lot of, Seth's points. I think that the need for proper examination of the eye health and the need for actually seeing a care provider it's hard to imagine that need going away for so many reasons. Even as it's just related to the consultative, back and forth with the provider, actually being there, taking the time, examination of results, and so in our view, the benefits are going to be on speeding up the process for the comprehensive exam, being able to do further, more comprehensive evaluations. But at the end of the day, I think that having a care provider showing up where the patient wants to be met, it's hard to kind of in our view have an evolution beyond that.
Damien Carroll, Vision to Learn. I'd say one of the aspects of sort of future technology we are most interested in the future is finding ways to communicate the results from our exams to a referral doctor. We really feel that we can help facilitate a smooth transition for a student going from our sort of one-touch, if you will, care, exam and glasses to having an ongoing relationship. Medical relationship with an optometrist or ophthalmologist could really be helped through the use of perhaps digital photography, even film, that could be relayed to a referral partner. We don't currently have that capability, but I think to your question for 5 years from now, I think that would be an interesting way to go and one that would really help to improve, again, that transition, which is so important to all of us, of a student whose first experience with optometry is from a mobile clinic that comes to their school, but then how do we also then transition that student into having a permanent relationship with a doctor in their community? And that kind of technology could be very helpful. I think that also answers a little bit your later question. Vision to Learn, typically, we've been around for 5 years now, so the repeat of schools has begun, and we typically go back to schools about every 2 years in the largest communities that we serve. However, we think it would be great if the students got their care a year later, a follow-up exam, and we do believe that by alerting the parents that the child needs the glasses, by having the child have such a positive first experience getting their exam and glasses, that it does, anecdotally at least, make it more likely that the child will then seek out that service in the year following. We also work with some terrific school staff, for example, a nurse in Long Beach who has monthly glasses parties with the kids, where she's checking to make sure that the kids are wearing their glasses and gives them little prizes to continue with that. So that relationship that we've built up with the educators and relationships with local optometrists is really a burgeoning way to help get those kids into that care and to start to have that yearly exam. And if they don't make it there, which, for the reasons that they didn't get it in the first place, some of them don't, we will plan to come back every couple of years to the school so that the kid's prescription can be updated and get a new pair of glasses.
Meredith Whiteside, UC Berkeley Optometry. In terms of the follow-up, for us at the time, it was ordered by requested by the responsible party and the PCP. So from that aspect, we did it. We also made sure that in our notes that we recommended appropriate follow-up. Technology, a lot of the patients that I have cataracts, so it's hard to do digital imaging on those folks. So some bread and butter, a little bit more older school optometry in terms of binocular indirect tends to help you better. But the one thing that I do like is it's getting lighter. So it was always very heavy with all these suitcases of equipment. So.
Any other comments from the panel?
So if I can make just a quick comment regarding the technology, I think that's an important point to bring up. Technology is fantastic. It can be used in a very good way, but we need to be careful that just because something that comes out that's shiny and new is now starting to replace what's been the gold standard and the quality of care that's been provided in the past. I work in academics, so we're very data driven, and so whenever these new devices come out, it's very important to ensure there's good clinical research that's done to back up the efficiency of the technology. And we know it's going to continue to improve over the years, but I think that's an important point to highlight as well too.
Any other comments from the panel?
Yeah, the only other comment I would say is the same, kind of to reiterate, is that it's quite possible to see 20/20 and have pretty serious eye disease, eye pathology, whether it be diabetes or glaucoma, so that you don't want to overlook the importance of that.
Any other questions? No? Okay, Dr. McIntyre.
This question, well, it's a two-pronged question, is anyone who is willing to answer this. First, how would a fixed location or brick and mortar mode of practice be advantageous over the mobile mode of practice? That's mobile clinic or home visit. So how would that be advantageous over the mobile? Once you have that answer, that thereby means there must be some disadvantage to the mobile mode. And can that disadvantage, if there is one, be mitigated somehow? And how would you do that? What process or practice would you implement to overcome that?
This is Gilbert Milgoza from VSP. Advantages of a fixed location, I think for me, it just depends on the type of, it's the customer that I'm dealing with. Usually in a fixed location, sometimes people are a little disadvantaged, don't like to cross certain borders, barriers. They want to stay within their neighborhood. So I find a fixed location a bit of a disadvantage to the underserved community. I found out that there could be a fixed location or a brick and mortar location just on the other side of this bridge. But because it's not in their community, they don't want to go beyond that point. So the advantage of a mobile clinic is we bring it to them. We usually work with some kind of a community center where they feel comfortable getting other services. So that's an advantage. Only disadvantage that I see of a mobile clinic is the terrain. Sometimes there are some very rural locations where the roads are not adequate for our units. Our units are 40 feet long, so we don't want one of our units belling, bottoming out somewhere. So that's the only disadvantage. Otherwise, we work with the partners to ensure that we have the proper location, that we're visible, and that everybody has access to it, especially if we're on a public transit system.
I can go ahead and comment. Rena Patel from Marshall B. Ketchum University. Advantage, clearly access to care. So just to dovetail on what was already said, if they're not able to have the services or go to the services and they're being brought to them, then that's taking care of a big problem. A disadvantage, and I alluded to this earlier, would be the continuity of care. So if an individual is seen for an evaluation on that mobile unit and they do need to go in for follow-up, now are they seeing different doctors for those follow-up visits? when they're coming back annually, is it the same doctor that's providing those annual eye exams? That would be something else worth thinking about. And then also stressing the importance of that doctor-patient relationship. So if they're seeing multiple, multiple providers, is that going to impact, the way that they're putting weight in terms of the treatment recommendations? So those would be things I would say would be on the disadvantage side.
Damien Carroll, Vision to Learn, would absolutely echo those comments. The ideal for any of these kids is to be in a long-term care from a optometrist, family optometrist. And I don't think we know yet how to arrive at that solution for all the hundreds of thousands of kids in the schools that we serve. We are cognizant that there are some benefits to the mobile care. One is that there's less time spent out of class for these kids. They're out of class for no more than half an hour and they're back in learning again. We also think that the school-wide provision of glasses, as I mentioned earlier, has a lot of benefits to teachers and staff being able to keep up with the kids and the kids feeling comfortable about wearing their glasses. But we very much want to work with the board, work with local optometrists to improve the way that students can then end up with an optometrist that they're going to regularly. That's the goal for all of us.
Jeremy Bornstein from 2020 Onsite. So I think some of the key concerns have been mentioned, right? So continuity of care and patient-doctor relationship over time. And so the second part of the question is, well, how would you minimize the difference of that impact between a brick-and-mortar location and a mobile location, non-fixed location? And so some of the ways that we have minimized that impact is through things like enhanced use of technology to ensure that we have electronic medical records so they can be easily transferred to referral partners, ensuring that we have multi-year agreements with clients and MOUs in place with community health centers and schools that we see so that students and the general population can be seen year over year, book their next year's appointment at the time of the visit. Working to ensure that the doctors are accessible, whether that's by email or by phone, and having a central place to call so that they still feel like they have a single provider. And so those are just some examples, but there's an extensive number of ways that that any of those what sort of at first blush on its face might be benefits of brick and mortar locations can be very easily mitigated just through enhanced investment in infrastructure and having the patient experience in mind.
Seth Shallett with Prevent Blindness. I think to your first part, there's actually a lot of synergies to having sort of a dual structure of brick and mortar and a mobile footprint or a mobile capability, particularly from a continuity of care and a patient care perspective. I think as I reflect, one of the things that I think is unique to mobile service providers, I think it's important for all of us to be able to, particularly those that are nonprofit-based entities, at least like Prevent Blindness and some of the others, the cost of operating the business model has to be viable. For example, as Damien said, their model is a very flexible, low-cost unit of service model. One of the challenges when you marry that with a traditional brick-and-mortar model is on the business mix side, how do you set up these entities such that you're not overburdening the cost structure in terms of managing and where the prescriptions are flowing from and things of that nature. So I think I look at it not just from a patient and a continuity care perspective, but making sure that the business mix is convenient to both, so that both entities could be set up in a most viable way that allows consistency of service. Because if you have to set up a mobile clinic and then down the road through economics that were not thought out early, maybe 10 months, 12 months, whatever that point in time, that mobile clinic then shutters or isn't able to operate, right? Then you have some challenges for the patients that have been utilizing those services. So balancing the two, I think, is an important component.
Meredith Whiteside, Berkeley Optometry. The other thing I would say in terms of advantage of a fixed location over a mobile clinic would be chronic disease management. The technologies that we have out there right now in terms of visual fields. I mean, they're lighter, they're smaller, but they're still not truly portable. Same thing with if you're talking about very, I think, acceptable technology that's being used more in offices such as OCT or ocular coherence tomography. So far, I don't see any portable models coming down the road. But if you're watching for chronic disease, you really need you need those technologies whenever possible.
So apparently a very good referral network
Yes.
before you're going into any area.
Yeah, it's very important to know your local doctors and have a good relationship with them so that you can get really immediate consults.
And Jeremy Bornstein from 2020 Onsite, just one quick additional comment. We do have a visual field that is that does fit in our mobile footprint, and so we use that as well. So it's something that is possible.
Any other comments? Any other questions? Dr. Turetsky.
Couple quick questions, primarily for SWTL, VTL, and VSP.
Ooh.
I deserve something for that. Where is there a brick and mortar location for the storage of records? I know they can be stored in the cloud, but I believe, you can correct me, I believe current regs require that there is a brick and mortar location for the storage of records and for patients to request their records or go to that location to get their records if they wish. Whoops, how do you guys do that now?
Thank you, Seth Shallett. SWTL is our acronym. Thank you. We actually do have a physical place of record. So we operate an office in San Francisco, and so we have record storage both in the cloud and patient record storage at San Francisco. So the clients that we serve have the opportunity to coming into our office during business hours, and they receive notification at the time they engage with us about what those business hours are. And we also have the opportunity to provide those records to them as well.
I'm just going to clarify the requirement for the brick and mortar location in the medical records. That's referring to 3070.1, that's related to those going into residential care facilities. The other is related to just maintaining the records over 7 years, but the actual requirement to have it in the brick and mortar is 3070.1 for residential care.
Gil Melgoza from VSP. We actually store our records for 7 years off-site in our warehouse. We provide a copy to the doctor at the event, and we keep the, as I said, our physical copy for 7 years, and we also scan them in as well. So we have an electronic copy, we have the physical copy off-site, and our partner has a copy as well. At schools, we do provide a copy also to the school nurse.
Vision to Learn, very similar. We have an administrative office in West LA where we store records, both the consent forms, all of our EMR records are stored in the cloud, but parents can call in and get their students' prescription and health records. We're happy to provide those to them. That office also handles the request for replacement glasses under warranty.
One more question. Sure. 2020. You had mentioned in your presentation that for folks that have a physical disability that you have to make special accommodations for that. What would be those special accommodations? Do you have a van that's specifically equipped for that purpose?
Yeah, so we do. So we have a AD&D compliant van. It has a wider door entry so that a wheelchair can fit in. It has a ramp that is like an elevator ramp, and then in the exam room as well, having a wider doorway. So, yeah.
Any other questions? No? Dr. Calgucci?
Okay, I'm going to shift gears just a little bit. There's been a lot of discussion from the panel, I thank all of you, about continued care, follow-up care, specialty care, etc. But I want to shift over to the business side of the equation a little bit. I'm just seeking any opinion that any of you might have around how we would prevent, as a board, having mobile clinics being used as a funnel marketing tool to funnel patients to specific doctors.
This is Gilbert from VSP. Whenever we do referrals, we provide the patient with a list of doctors in the area. The doctor that is also volunteering on the mobile clinic is on that list, but it's basically, they look at it what's closer to their home. We also have a gift certificate program where the gift certificate program will provide an eye exam and glasses at no cost to a patient. We also provide a list of doctors by their zip code. So we never really funnel anybody to or elevate anybody's practice on charity care. It's the patient's choice to where they want to go, and we provide those lists.
Similarly, for Vision to Learn, our referral list states specifically that we are not endorsing any particular of the providers. All of the lists have at least 3 providers. The one that we use in Los Angeles has, I think, 12 providers on it. We also have a strict prohibition against any of the optometrists that we work with self-referring to make sure that those lines are not crossed.
Yeah, Jeremy from 2020 Onsite. We don't have, outside of having a specific provider that we work with from making it easier for the patient to have access, we have no financial relationship with any of the providers. And so, that is obviously a requirement and would have to be a requirement.
Prevent blindness. To your question, we operate very similar to the other folks on this panel in terms of our procedures for referral. But if I understood your question, it really is getting at the heart of, how do you, as a board, know that there isn't a pay-to-play or a referral issue with too many referrals going? And I think there are many ways that the board can consider approaching that. One of that is, self-submittal of referrals to the board, in terms of if you're looking at regulations requiring providers to self-submit when referrals are made, and then providing some cross-checking on how many referrals have been to that specific practice or ophthalmologist or optometrists. There is certainly through online capabilities. There are databases, for example, that we work at Prevent Blindness. We do a lot of training with CHDP. We provide vision screening training, and there may be mechanisms in place today for other agencies to be able to provide those tracking and referrals and provide some data back to you or to the organization so that you can do some pattern recognition or analysis. My assumption is your question probably stems from ensuring there may be mechanisms to detect and weed out when you do find those instances that you feel might cross the line of too many referrals or some level of, for lack of a better term, pay to play.
Any other comments from the panel? I have one for Ms. Berber, who asked me to ask this before she left. She had a question about ballpark, approximately how much money does it cost to have a mobile clinic? How much does it cost to physically put a mobile clinic together? And what are the hard costs in terms of running a mobile clinic?
This is Gilbert Melgoza from VSP. I have 3 mobile clinics, and I'm very fortunate that I'm fully supported by a VSP and I have a budget. Each one of our mobile clinics costs about $400,000 to fully outfitted. And to operate, I have $800,000 to operate these clinics, and that means staffing, feeding the staff, fuel, repair, and I would say the most expensive hard cost would be repairs. They travel around the country and things are always happening just because they beat themselves up as they drive across the country. So that's something that we have to budget for. But we have a lot of travel costs as well because sometimes what we do is we look, they're called MRTs, mobile response team members, and they are They are registered employees of VSP. And if we have events happening on the East Coast and we have offices there, but if nobody volunteers, we have to fly people from across the country to make this happen because we've already committed to the partner that we would be there to provide services for them. So there's a lot of other hidden costs, just RX pads, miscellaneous office supplies. So, but the actual unit itself, it's about $400,000.
Vision to Learn for the last few years has moved towards a Mercedes Sprinter model of clinic. Our very first clinic back in 2012 was an RV, a 2 optometric lane RV. These Sprinter clinics have worked out better for us. They're a little more maneuverable getting onto school sites, a little more economical to drive around, find parking for, etc. These clinics cost a little over $100,000 between the purchase and the outfitting of the optometric equipment, electric, cabinetry, it's putting on the jacks and so forth. And then the first year cost, it's about $100 per child for program costs. These clinics see at least 3,000 kids in their first year, sometimes up to 4,500. So it can be anywhere from $300,000, $400,000 in program costs per year.
2020 onsite, I would just say our build-out costs are similar to the VSP costs.
Prevent blindness, see well to learn. I would concur. I think we have some general cost synergies, but I think if we look across all of the providers here at this table, you'll probably find some disparities in the types of vehicles that we have, for example. And part of that goes to where are the services provided. There are some economies of scale. For example, some of our partners here use a 2-lane vehicle. Our vehicle has a 1-lane, maybe 15 or so exams per day. So costs can vary widely and depending upon the level of services that are also provided. I think where you see some uniform consistencies is rates for optometrists should be relatively consistent. But it really depends upon the scope of services, and quite frankly, the cost to provide services is dependent upon whether there is an ability to bill Medi-Cal or to provide and receive billings versus whether you are receiving and making exams and then really are dependent upon a traditional nonprofit model of philanthropic support. Because that obviously changes many of the considerations that one might want to make about the type of vehicle that is most sustainable over time beyond the initial costs.
So now my questions. I have a quick legal question. I just want to make sure I'm correct on this. Current law stipulates that an optometrist cannot go into a home or a school and conduct a comprehensive eye exam, correct?
Not standing alone. So the way that the statutes are structured, a close reading suggests that you have to tell us, you have to get some sort of statement of licensure. You have to tell us before you practice where you're going to practice.
So a current licensed optometrist could not say, I'm going to volunteer my time, adopt a school, and go in and do comprehensive eye exams under current law?
I would have to research that a little bit more, but like I said, without fitting into one of the exemptions for temporary practice, there is an exemption for temporary practice, or one of our mobile clinics associated with the school, I believe you are correct.
Rachel, just a quick follow-up.
Yeah.
Kurt, as you answer Rachel's questions, and particularly the last one, could you specify whether it's a statutory prohibition, requirement, or a regulatory? Because it'll help me kind of fathom
So I think
what
if
the
you
solutions might be.
Certainly, sorry to interrupt. So I believe under the current statutory scheme, starting off with 3070, it suggests that prior to practice, you tell us where you're going to practice, and we issue you a document essentially saying you can practice there. Now there are some cutouts, my words, cutouts in 3070.1, but none of those cutouts to me are indicative of like Dr. Welby, MD. I know I'm dating myself, taking your little black bag into the the bedroom or the house or whatever and doing that. That does not seem to be contemplated by the current statutory scheme.
So I have a couple of questions. One is, you have, how many mobile clinics? I'm sorry, we had a lot of information.
Prevent Blindness, See Well to Learn has one mobile
One clinic, and you're only in the Bay Area, correct?
currently only in the Bay Area. Correct?
Do you have plans to expand anywhere else in the state of California?
For See Well to Learn, we are contemplating that.
Okay, and you have 6?
Yes, Vision to Learn has 6 clinics, 4 in Southern California, 2 in Northern California.
Okay, and you have 3 nationally, correct?
Correct.
And that's it in terms of mobile clinics that we know of in the state of California right now?
Well,
There's others, but in terms of,
UCSD, Jules Stein.
UCLA, UCSD are 2 that I know of as well.
There's a clinic that's serving Fresno Unified. I'm forgetting their name. They're a religious nonprofit, I think.
I'm not aware of that. And, you know, some of the other, what I would call ancillary partners, such as the Lions Club, for example, I know that from discussions that I have had, they are also contemplating looking at mobile capability as part of their services as well.
okay, because in looking at, I'm actually on the Vision to Learn website at your map, it seems that a lot of the mobile clinic services are either in the Bay Area, Sacramento, Fresno. You know, we're missing a lot of parts of the state of California that, you know, when we talk about access to care, you know, there are a lot of the underserved communities aren't getting the services that I think they need to be provided. So one question is, if the board were to look at different ways to allow vision services to be provided throughout the state of California, is there a network and is there enough folks to service people all over the state? And I'll use an example, and correct me if I'm wrong, I believe we had a presentation on our children's vision work group. Was it Glenn County, where there's literally one optometrist?
Right.
And, you know, when we're talking about, in the case of seniors or in the case of children, you know, one optometrist to serve that whole community. So how would you suggest, as a board, we look at providing, what barriers could we get rid of in order to create greater access for folks all over the state of California? You know, I'm thinking Central Valley, Salinas, going out where the farm workers are, or looking in the deserts of California and North State. For me, if we're going to do anything around this issue, it has to increase the availability of access to all Californians, not just in these centered population cities.
Yeah, I'd be happy to speak to that. So in terms of the question of capacity, obviously some areas it will be more difficult to find optometrists than others. And to date, Vision to Learn has used our clinics to do sort of satellite service to some of these areas. You mentioned Fresno. Just last month, we brought the mobile clinic up to Livingston, just north of Merced, to serve kids and actually some of their parents for a project with United Farm Workers. These were farm workers in the Salinas area. So, you know, on a case-by-case basis, you can have a clinic that's based in one region that can take a trip to serve students up in that area. The biggest barrier right now to expanding further into the state is the inability to receive Medi-Cal reimbursements for this service in most parts of the state. There is a pilot program in Los Angeles County that the governor is looking into the impact of mobile vision care that allows for some reimbursements through Medi-Cal currently, but it's only in LA County. And the Vision to Learn service in other areas of the state is entirely privately funded through philanthropy, donations from corporations, foundations, sports teams, individuals, et cetera. So that would be, you know, really a huge help to allowing us to serve the areas that you mentioned and expand outside of the regions that we currently serve. And we're eager to do that. You know, we share the concern that these are areas that are currently not receiving services, and the kids are in particular need.
Seth Shallett with Prevent Blindness. The question is a very interesting question, because you're quite right that outside of the higher concentrated urban areas, Part of the challenge is it's an economy of scale to make a cost-effective ability to deliver the services. For example, Prevent Blindness maintained an office for 20 years in Reading, and we have provided services to Migrant Head Start and services all throughout the state, mostly in chart-based screening and in limited autorefractive-based screening, but not our whole mobile optometric program we call under the umbrella of See Well to Learn, in part because it's been, one, an economy of scale. You need to have enough concentration of patients to make it economically viable. But I will echo what Damien said. I think the biggest barrier is that, as I understand it today, a mobile clinic that is not affiliated with a federally qualified health center or a standalone mobile optometric service does not have the ability to bill Medi-Cal for its services. And it puts an over-reliance on the traditional philanthropic model, which has, by and large, worked well, but part of the challenge with philanthropy is it's very inconsistent. And what you don't want to do is be in a position where you offer services to a community or an area and have to cut back on those services the next year or some quick time period because the sustainability piece can't be solved. So finding a way to offer billing services or to collaborate perhaps in a more effective and economical billing network with local optometric providers, maybe other creative ways we could look at how we can solve that dilemma.
2020 onsite. So I think one of the interesting things about the current statutory model around school visits is that with the concerns around continuity of care, the only place where we're allowed to deliver mobile services right now is schools. And if it wasn't children that we wanted to protect with the current laws, who would we want to protect, right? That should be the highest standard of protection, and that's currently allowed. So from a from that perspective, I would say there's certainly some potential change in thinking there on how do we deliver that same how do we put the proper regulation in place to ensure that those individuals are protected, and then how do we make it available to other people as well. On the communities piece and sort of being focused on specific geographies, we have different clients that we'll visit that are up to 200 miles away from our central locations. And so we have situations where we'll actually get hotel rooms, we'll stay overnight to deliver services. And so if there is a demand and if there is there needs to be some concentration of people. If there's one person, then that person probably needs to drive, or there needs to be, some sort of nonprofit model that allows, an individual that's just roaming on their own. But to the extent that there is sort of a concentrated population, there's certainly, if the market is regulated and allows for mobile optometric services, those individuals are very, very likely to be served.
Just a quick question, does Medicare cover in-home optometric services? I don't know if anyone can answer that. Do you know?
Could you answer that? I think.
Does it? Oh, yeah, then thank you, please share.
Medicare will cover in-home physician services. Optometrists are physicians under Medicare. There's certain caveats that go with that. As far as an optometrist goes going into a home, you're going to probably want to have a physician's order requesting those services, and you can still run into issues with billing because there are certain codes for billing Medicare, and in-home services tend to bring up red flags. So yeah, it's theoretically allowed, but there are some barriers to it.
When you're talking about in-home, you're talking about nursing facilities or
No,
private
talking about
homes?
going to, Mrs. Smith's apartment.
So to the case we were talking about earlier, if particularly a senior, is wheelchair bound, homebound, Medicare would cover optometric services in their home, if it's referred by a physician.
That's just an extra throw in there to be sure that you would probably be compensated. They don't pay for refraction, so Medicare never pays for a refraction. In general, though, you start running into issues with billing if the area you're going to doesn't have an NPI number, National Practitioner Identification Number, and a home won't have that. So it can be done. It's difficult.
Wait, I have one more question. So an optometrist is allowed to go to a person's private home?
Not in California.
Not in California.
She was just asking if you could bill for it.
But in California.
But in California, you cannot do that
No,
currently.
I can't go to your mother's home and do an eye exam in her personal residence. I could only go and see her if she was in a nursing facility.
And
Not
that's
an
state
assisted
law.
living facility,
Got it.
not a memory care facility that isn't also a skilled nursing facility.
Okay. But a medical doctor can, right? And a veterinary, that could go in.
Take care of Mrs. Smith's dog too.
If I may just add one thought, it also depends upon how we choose to define scope of mobile services, right? Because that is a fairly broad and sweeping capability. Are mobile services, could they be considered to be telemetric services? Could they be considered to be bringing autorefractive services on site to Mrs. Smith's apartment, but maybe not dispensing glasses or providing other higher level of services? So part of it is, to my mind, also agreeing on the scope of services to be provided sort of in a non-brick and mortar environment and how you define what those services are and partition them out.
And at this point, and I could be wrong on this, Medicare does not pay for telemedicine services unless you're in a certain rural area that they define that has a shortage of practitioners.
That's my understanding as well.
I have nothing further. Dr. Wong?
No, my question was about billing and about reimbursement. So it was enlightening to me to find out that no mobile services in the state of California can bill Medi-Cal or Medicare. So I think that's definitely a significant barrier.
Any other Mark?
Sorry to take a second bite at the apple. If you'll indulge me for a moment, I want to do a little kind of thought experiment. So let's say I had a magic wand and I could sweep away the laws that restrict the ability for anyone to do mobile optometric care. I see in the materials in our agenda that probably a majority of the states don't regulate mobile optometric care. It's perfectly legal, or not regulated. I note that if I am a MD, I can get a taco truck and I can go and provide medical care wherever I want. Indeed, if I'm an ophthalmologist, I could take one of your vans and provide those services, and I'd be totally exempt from the regulation or the laws that we enforce, and provide the exact same thing that an optometrist would provide. If this magic wand swept away the laws prohibiting mobile care, if this mobile optometrist were to commit malpractice, a plaintiff's lawyer could still sue that person for malpractice. If the mobile optometrist were to provide a lower standard of care, have unsanitary conditions, not refrigerate the medicines that our regulations and statutes require, this board could still go after them. So what are we gaining? I mean, it's kind of like a so what question. I mean, if this statutory and any regulatory provisions were swept away, are we in the same place? It doesn't matter that there are wheels on top of the facility that the optometrist provides care.
So with that, we're going to give you a lunch break to contemplate your answers. We'll take 20 minutes. For those who are visitors and thinking, where are you going to go in 20 minutes? There is a cafe to pick up food directly across the parking structure in the building next door. So feel free to pick something up there and come back and join us. We'll shut the webcast down for about 20. We'll regroup, and it is a working lunch. So we'll look forward to your answers and then picking up with any additional secondary questions from the board before turning it over to public comment and moving through the rest of the agenda. Thank you. We'll now reconvene following our lunch recess. And I'd like to ask Mr. Morodomi to recap his question again that he posed to the panelists for their review and consideration during the short break that we had.
Well, I can't do it as eloquently as I did before with having lunch inside of me, but basically it's the question is basically a so what kind of question. You know, if there's no regulation in this area, you know, what's the public harm? I mean, do we still have enough protections, regulations, et cetera, to protect the public? And noting that other states don't regulate this, and that an ophthalmologist can do the same exact thing without regulation.
This is Gilbert Melgoza from VSP. I've been thinking about that big wand you were talking about wiping everything away and how it would impact. And as I thought about that, you know, if we had no guidelines and regulations, what that impact would be. I don't think there would be impact to us because our program is strictly charity care. So we have a high standard of what our clinic looks like, our standard of presentation, delivery, and so forth, and it's the doctor or the OD or ophthalmologist that delivers the care. So we provide the vehicle and the shell and work with that doctor to deliver that care. So all those guidelines and regulations, if they were gone, that would fall upon that individual.
Yeah, from 2020 on-site, I think that's exactly right. I think that all of the laws and regulations would still apply. They attach the optometrist or the practice owner if it's an optometrist or ophthalmologist, and so you know, anything around design of the practice, those laws are still there, and you know, they need to be respected. The enforcement action and rights of the board still apply the exact same way. Even in states that we operate in where mobile optometry is regulated, Illinois being the example, the requirements are, you know, are specific pieces of equipment that need to be available on the mobile unit. They are they're, you know, notices to the board, no actual confirmation, just simply mailed notices to the board about location. And I think that the reason for that regulatory framework is directly related to the already existing robust framework that practitioners need to abide by.
See well to learn, prevent blindness. As I reflect upon your question, I think from our perspective, our principal goal is to ensure that we can serve as many low-income and underserved children as possible. And any impediment or regulatory barrier that makes those hurdles too onerous is something that we would want to be able to dialogue on. Clearly, the caveat is as mobile services become more prevalent and as that delivery model over time becomes more normative, educating the public about how does one lodge a complaint? Where would one go if there is not a relationship with a brick and mortar facility? I think those consumer protections obviously are very, very important. You know, today's regulations probably were put in place without probably anticipating where mobile optometry and those type of services would eventually evolve. I only again state from Prevent Blindness's perspective, we would like to advocate for the fact that we would like to see regulations make the hurdles of reaching those that have difficulty availing of these services because of financial viability or lack of awareness, we don't want to see those barriers raised.
Damien Carroll, Vision to Learn. You know, as an organization, our mission is to find the kids that need the help. And in order to add that capacity and make the investments to do that, I think it's helpful for us to have some certainty and stability going forward. So to the extent that there is some uncertainty in current law in regards to the practice of mobile optometry, I think we would like to see that resolved and in a way that really protects patient safety, accountability, quality of care, in keeping with the brick and mortar optometry standards that are currently existing. So, you know, I agree with the panel. I don't think that a huge amount is necessary, additional regulations, but I do think that adding some certainty and stability going forward so that everybody is very clear about the parameters that they're operating under would be very helpful and would help to bring this service to more kids and seniors and people who are not currently able to access optometric care.
Meredith Whiteside, Berkeley Optometry. One of the ideas behind our program was that we were not meant to replace the brick and mortar. These are people who would simply not get care, or their general physician would be trying to give them care. And I still feel that I think that there's technology is getting better, but given the average, office, I still see advantages in terms of being able to follow chronic conditions on a regular basis. I am concerned that a lot of times there's a perception that, oh, well, I see 20/20, so I'm fine, I'm great. And there's a lot of people who see 20/20 and have diabetic retinopathy. There's a lot of people who see 20/20 and have glaucoma. And in terms of monitoring and caring for somebody with glaucoma, I don't feel that in a mobile situation you can have that level of care. You have vision tests, visual fields that are more mobile, it's true, but if you look at the gold standard of glaucoma care in an able-bodied person that's able to go to a traditional setting, I think it's my opinion that I think they would be better served by brick and mortar.
So as a follow-up to the question,
Yeah.
that answer, and this is a topic or a balance that I always struggle with, and that is the extent of the care, the testing you have, versus the people who would never get the care in the first place.
Right.
How do we help me balance that, right? If help me try to figure out the answer to that.
Yeah. I mean, I can only talk about our organization, and it was based upon the fact that people had a documented need. That was how we made that decision, was that we weren't referring patients to ourselves, we were having a disinterested party refer them. So, the doctors that would refer to me, they gained nothing from the referral. I gained nothing from that. It was kind of a disinterested party that was making that referral.
Any other questions? I have a couple more questions. So I understand, first of all, for 20/20, who are your competitors nationally? Do you have any competitors nationally?
It is not obvious to us that there are other real competitors. There's certainly other programs. Obviously, the other folks at this table, there are certain organizations doing pop-up clinics where they'll actually go on site and they'll set up what is, they'll set up equipment, transportable equipment and do exams. We are not aware of another provider that is trying to become the national platform for mobile service delivery.
So, because you're for-profit, so you're the only for-profit mobile clinic company in the country?
I can't.
That, to the
I
best of
can't.
your
Yeah.
knowledge, I mean.
Well, we are the only. I would say we are most likely the only optometric practice management company that exclusively does optometric practice management. The distinction on the for-profit one, an insurance company that does a pop-up at a commercial location would, in my understanding, I don't know the structure, but would presume it's for-profit also. There may also be, there is definitely other individual optometrists that do provide elder
I'm just
care.
talking, you're the only for-profit company with the van that's cruising around going up right now, currently. I mean, I would assume that down the road, I mean, look at what happened with Uber. I've got Lyft, you've got all kinds of other things, but I'm just trying to.
Go ahead. I'm happy to.
I think you're raising an interesting point, and one of the things to make the board aware of is there have been some changes over the last couple of years in entity structures, business structures in the nonprofit. California has been slower than some states to adopt different models, but there are what's known as hybrid models, where you can now have a for-profit and a nonprofit entity combined and or separate, but under the same parent umbrella. I think, to your question, as those models begin to take hold, as the kinks are worked out, I think there's room in this space for that type of growth. So I would not be surprised if we were here 2 years from now or 3 years from now to see a much greater mix of for-profit and nonprofit entities trying to serve this model. Because part of the challenge is philanthropy is not consistently sustainable. And without the appropriate ability to entice and raise capital, you can't attract sustainability. So there are, and California now does have a few hybrid LLC type vehicles that I think will evolve over the next couple of years and allow others and perhaps larger providers to service this space.
Well, let me put it in context of why I'm asking. It's because a lot of the dialogue we've been having is about underserved, it's about certain poverty levels, which I absolutely agree with, but I also think there's a market for people like me, a working mom with 2 kids. And it is hard sometimes I'm always looking for how I can make my life easier. So just because I get that there's all this emphasis on underserved, I understand that, but what about the market of people who have insurance? I mean, I have VSP insurance, but I have to go to a brick. If I could have someone cruise up to my house,
Right outside.
then, I would consider that, because part of it is how, that's where I see our society going. So my question is, if we were to Mark's point, change some of the regulations, are we going to create a food truck mentality in California where there's all of these other mobile clinics in other parts of the country that are going to flood our state, which then could lower the quality of care everyone is getting? So I want to know right now how many for-profit mobile clinics are out there. Not pop-ups, because pop-ups don't do me any good. I want on wheels. How many are out there?
I prevent blindness Northern California. I don't have the data that you're asking for, but I might suggest that, for example, outreach to the Kaiser Foundation or some other entities that may have visibility into the data. I haven't seen, at least in my experience in the 3 years being with Prevent Blindness, focused on Northern California, I cannot recall seeing any specific for-profit entities. But if I take off my current nonprofit hat, I spent my earlier career in the private equity center. And I think the business model that is actually more viable is the model of being a concierge type of service, servicing that busy mom or that busy family, because that's where the profit is. And so I think you're asking a very interesting question. It, of course, is difficult to look around the corners and anticipate how this market may evolve, and, you know, if you would see any degradation in services or how those services change. But it's been a for-profit model principally because, frankly, it hasn't been a financially viable model for other organizations to chase. As that changes, I think you'll see the dynamics in the players shift as well.
And from 2020 onsite, I would just add to that. So, you know, we're aware of maybe 20 or so different mobile type models. Some of those are for-profit, some of those are not for-profit. The other for-profit ones seem to be individual, you know, a single optometrist decides I'm going to create a mobile unit and I want to serve elder care facilities. That does exist for sure. I think it comes back to this, you know, so 2 points. Is there going to be a flood of for-profit entities that come in and lower the standard of care? On that, there's two pieces. One, you know, when I look at our model and really any model, is there's still a requirement that the optometrists are licensed in the state. And so the optometrists are still going to have to be locally trained or at least locally licensed. So they're going to be vetted. And they're still going to be held to the standard of care. They're still going to be held to, you know, all of the laws and regs. And so it doesn't change, the dynamic does not change because it's mobile versus because it's brick and mortar. Because the same, you know, it would be a parallel thing to say, well, why don't you have a flood of people opening brick and mortar chains that are lowering the standard of care because you're allowed to open brick and mortar chains? And so I don't think there's I think it's a distinction without a difference. And so, you know, that's sort of how I look at that. In terms of the, I guess I would sort of ask back specifically, in terms of is there a specific sort of question behind the question or concern around there only being a single, you know, a single entity that's doing this right now? Like, does that raise some policy considerations for the board?
I'm just trying to figure out and see what's out there because, you know, California, we're the biggest state. We've got the biggest population. People come in here and it's a gold mine. I mean, that people can make, and I just want to make sure that, you know, competition, in my opinion, breeds better services. And I just want to, as we're considering some changes, if that is the will of the board, that we are keeping that. And I want to, again, you have to weigh that with access to the entire state. I mean, we can't just sit here and think about San Francisco or LA or Sacramento. We've got to think about Redding and Temecula and Salinas at the same token. And so, you know, we're very diverse and we've got to protect that. So, is there any?
Yeah,
and then I'll get to it.
Gilbert Milgoza from VSP. I don't have that data for you, but I do have a resource for you. I'm a speaker at the Mobile Health Clinics Association, and it's one of the largest forums of all new mobiles and people who want to start their mobiles. They have something called the Mobile Clinics Roadmap, and it might be on their website where everybody who signs up and registers will indicate where their mobiles are within the country. So you might be able to pull a report by state.
Thank you.
Just a really quick question. I don't remember who, you also employ opticians, right? Now, do they have to be licensed to work, or are they working under the doctor's license when they're working in the mobile clinics? Are they licensed, or, you know, like they've taken the national exam and then they're registered through the state of California?
So some of our opticians come on starting without, and then they get their license.
I think Dr. Manna can speak more to this.
Our managing optometrist is here, has a little bit more information about that.
Is that accurate?
Yeah. So we're actually working on making sure that all of our opticians are licensed, and especially all the opticians who do dispensing have to be licensed. Some of our opticians are solely on the mobile clinics and work under the doctor. But we would like to get all of our opticians licensed.
Can I ask a follow-up to that then? What do you have in process to make that happen? Is that just a long-term goal, or do you actually have?
No, we're actively,
We're actively ensuring that all of our opticians, I can't speak to how many opticians we have right now, but it's under 20, so we have direct contact with all of them to make sure that they're working on getting licensed if they're not already.
So Mr. Bornstein, I apologize in advance. This is kind of a loaded question, and you can just nod your head or just and somewhat rhetorical. But it's the flip side of what member Michelin asked. 2020 Onsite seems to have it down, right? You practice or you deliver services in Illinois and Boston, and the model seems to work. You're complying with all the regulatory requirements. Your vans look very beautiful, clean, etc. And you're the only game in the country almost. If this board were to create some very rigorous regulatory requirements for mobile clinics, I have no doubt that you would be able to comply with your 2020 Onsite would be able to comply with them with very little adaptation. But your competitors, the growing new competitors, may not be. So that if we pass regulations that are very difficult to comply with from the mobile clinic realm, we could create a very lucrative monopoly for you here in California. Is that a possibility?
Jeremy Bornstein, 2020 Onsite. Thank you for suggesting that possibility that you would be willing to do that for us. That's really not that's really not our intention. In my presentation, one of the things I talked about was sort of the purpose of optometry law being consumer protection and efficiency of delivery of care. And so for there to be efficiency of delivery of care, there needs to be access, and for there to be access, it needs to be it needs to be a model that can be replicated. And our interest isn't to stifle competition. Our interest is to improve access, look after people that are from all walks of life, whether they're underprivileged children, moms who have kids at home who don't have time to go see the eye doctor, or a patient with diabetic retinopathy who otherwise wouldn't go see an optometrist because there's no optometrist at their community care center. So, I think having a regulated environment is better than an unregulated environment because it creates certainty. At the same time, I agree to your point that it should not be formed in such a way to stifle access because it puts too onerous requirements on independent providers who want to serve the communities that are most in need.
Prevent blindness, see well to learn. To just address your comment, our model, as I mentioned before, is principally a philanthropic model. Healthcare foundations, high net worth donors that have a particular interest in our service areas. And in conversations that I have, regulatory risk comes up. It comes up in the context of where do you see regulation, and could you envision being shut down by any state licensing board in the future? So if I were to put down a certain amount of capital to help support your growth throughout California, what risk is there out there that we may not be able to achieve that? And obviously that's a question that I'm not able to directly answer, but to a comment that I think Damien at Vision to Learn made earlier, I think certainty benefits all players. So rather than what has been, I think, historically an unregulated approach, I think is fine, at least knowing where those regulations may go, having some degree of certainty on what that roadmap might look like, what the timelines are for considering certain regulations. The concern that I have, and I know that select funders that I speak with, is there is an opportunity to increase capital flow to this area, particularly, as you had mentioned, with some of these newer business models coming into play. But one of the drawbacks is the regulatory risk of uncertainty on where that may be down the road, and that has been not a large prohibitor, but a looming larger prohibitor of attracting large capital inflows to our sector.
Anyone else?
Any other questions?
Okay,
Ms. Brandbein, do you have
thank
questions?
you. No questions at this time. Thank you all very much for your participation. We're just going to shift to the next agenda item to get a perspective outside of California. And then we'll have a very engaged conversation around key issues, potential next steps, etc. So you may want to just stick around a few more minutes if you're interested in participating in that agenda item. Based on a few of your slides, I'd say you're very interested. So why don't we shift now to Jessica, and if you could take us through ARBO and what research they've done.
So members, what I did is I reached out to ARBO, that's the Association of Regulatory Boards of Optometry, to survey all of the boards in the United States to find out where they stand, what if they have restrictions on mobile clinics, if they have any statutes, regulations, if they require locations to be registered. Not all have responded. We're still in the process of following up with several states, and also what they provided. We've done some follow-up questions. What I provided is a chart of what we have found so far.
Questions of board members on the information Ms. Sieberman has provided us? Let me try this with the mic on. Any questions, Dr. Kawaguchi?
I just want to clarify on some of the states where it states in the summary that there's no specific law written or nothing was defined. That doesn't necessarily mean that there's not regulation that would attach to mobile clinic, correct? Just like our state. We have certain regulations that are not specific about the mobile clinic, however, it would affect one's ability to have a mobile clinic.
Right, and so what I found is some of the states who answer in those one-liners or simply no, we've done some follow-up questions with them to find out exactly how that plays into mobile clinics, if that means that mobile clinics aren't operating or they are operating and they're just not regulating. So we've done follow-up work and we haven't received those responses back yet.
So thank you very much for that chart. It was very helpful. Do you have any kind of additional narrative from the states that do not regulate this area? So for example, and maybe ARBO doesn't have this information, but so for example, it could be one of many responses, but the two responses I might think of is, gee, we don't have any laws or regulations regulating mobile clinics, but oh my gosh, it's a huge problem here, and we can't get the laws passed by the legislature because of one or two reasons. Or is the narrative, well, we thought of it and it's not a problem. You know, there are mobile clinics all over the place and they seem to provide the same quality care or sufficient care, and we thought about it and we decided we not to regulate this.
So of those who have responded no, that they aren't regulating it, I've done follow-up questions to find out then how are they ensuring that the consumers are protected if these services are happening. Some of the responses I've received is that they're held to the same kind of standard that they would be for any optometrist operating within a brick and mortar. That's their response. They're held to the same standard. But when you look at things like this, the follow-up care that's provided, the consumer notices to make sure that those are posted, there's a whole other avenue that I still haven't had those responses back from the states to see how they do that, or if they feel that it's not necessary to carve out just for mobile clinics if they think that what they have in statute is sufficient. So we're still working on that.
Any other questions from board members? Public comments on the outside of California study? No public comment? All right, let's go ahead and move to agenda item E, which I'll ask Ms. Michelin again to facilitate the review and possible action regarding mobile optometric practice and related laws and regulations. Ms. Michelin.
I think the best place to start is, can we just open it up to board members and see what comments or suggestions they have on taking the temperature? Do we want to move forward? You know, what is some of the insight of members of the board? Yes, Mark? You'll start.
I'll start just to start the conversation. So my thinking at this point is that one approach is to take bite-size bites of this topic. I mean, it started off as mobile clinics, and that appears to it's a pretty big issue, I think, with a lot of interests and interest groups involved. As I mentioned at the beginning of my remarks, when I stepped into this room, I was most concerned about the house call issue. And that seems to be a kind of immediate, immense problem because people are not getting care and our seniors are not getting care. So my question is, can we address that particular subtopic immediately, either through a regulation that we can do? It takes time, but it's something that we can do through it, and if it's a matter of just kind of interpretation or education, can we address this through an advisory? Because I look in the regulations or at the statute and it talks about temporary practice, and that's kind of a stopgap. Is there room in the statute that we can interpret to allow the house calls? And this is one area that we should have in-depth discussion with our counsel. And I know there are limits as to what a regulation can do versus a statute. But in this particular area, when it's providing services to homebound seniors, I as a member am willing to take a expansive interpretive role of the statute to allow for house calls to seniors, whichever regulatory way we can do it. And then finally, if we can't do it by regulation, maybe this is kind of a carve-out statute or something like that that we can work on kind of separate from the larger issue of mobile clinics. So that's how I'm beginning my remarks.
I guess my question is, can you just, I see where you're going with house calls, but you're saying seniors, but what about disabled? What about, so you'd have to define, or is it open to anyone? Can any patient, can an optometrist have a license, a pocket license?
I start with the position of, why can't an optometrist do a house call? A doctor can do a house call.
So if I could interject, I think, like you're saying, there's definitely two different populations, but the people who need house calls, the seniors, the handicapped, the ones that can't physically make it to a brick and mortar location right now, maybe like what Dr. Whiteside was saying, if you can get a physician's referral, so this is somebody who physically cannot make it into an office but needs care, then we would ensure that it's not just like a random Joe person who says, I don't feel like going to my optometrist's office, I want a house call. It has to be someone who's physically incapable of making it into an office but needs care. And I think that way it might ensure.
But why? I mean, why if I am an optometrist and I'm thinking that my business model now is to be concierge medicine? I mean, that's one of the growing practices in the state of California. Physicians are doing concierge medicine. So why shouldn't I have the ability, if I want to be able to say I want to go into people's home and offer that, why can't I do that? Why are we kind of discriminating between populations? I'm just asking. And then I have one other question. So would my current insurance pay? Would VSP pay my same benefit if the law allowed an optometrist to come in my home, I don't know, I'm asking. I don't know if someone from VSP wants to answer that.
I'm not an expert at insurance, but I don't think there's any, as far as I know, VSP pays what VSP pays.
Regardless of where. If it's a VSP doctor, then.
That's my understanding. I may be incorrect, though. Yeah.
Sorry, John. Come on
Counselor.
down.
I'm John Valencia, contract counsel for VSP. The short answer, our principals had to get back to the office. The short answer is I'll emulate Mr. Hepler and say I'll have to research and get back to you. I can tell you that as any of you who are covered by any form of insurance know, the provider has to first be impaneled. And so the provider needs to be assessed, and typically that assessment, based on the state we're in, takes into account what's required of that provider to even be in the business of either optometry or ophthalmology. But as to the question of in-home, it's a novel question to me, so I guess I'll have to research it and get back to you.
So Member Wang, in my mind, it maybe doesn't matter, because I don't want VSP to say, well, we'd love to, but the Board of Optometry doesn't permit this, so we're not going to reimburse you for it, right? So let's get us out of the way and throw it on to VSP if it is an issue.
So from my own experience with VSP, and for the folks in the audience, my group is the largest provider of skilled nursing facility vision care in California. And after negotiating with VSP for a while, the computer systems do not allow you to enter for billing unless you're doing it in your office. It has to have an office code. So with us working in a skilled nursing facility, for the longest time, there's no skilled nursing facility code in the VSP system. So we would have to submit HCFA 1500 forms, paper forms, that would have to be approved based on our location and with our contractual arrangements with VSP. And now they have a system set up where we send in the data, they fill out the HCFA on the VSP side, and we submit for payment. But from what I understand of the VSP systems and from the folks we've communicated with over the years, the system itself is only set up to deal with specifically in-office brick and mortar issues and nursing homes with contracted providers meeting all VSP's requirements to be on that panel.
You have firsthand experience, I don't. I can tell you by parallel that part of the reason mobile care is a novelty in other insurance spaces is why you have a pilot project in Medi-Cal, which also requires the same requirement for enrolled providers to bill from their registered location, which is the admitted location in Medi-Cal. That's what makes the current mini pilot in Los Angeles such a novelty for the providers and for the entities that are contracted in LA. So it's not atypical. But as far as the individual house call, I mean, I'll just have to research and get back to the board.
IMED, for instance, they have a mobile clinic provider application since they're dealing with throughout the country, and they allow, if you're approved from the application from what I've seen, if you're approved, you can provide services wherever you're legally allowed to provide services in your state, whether it's in a home, in a school, in your own office.
Any other comments on? I think.
I just want to say I do like. I mean, we've got to have different sources. I do like the mobile clinic, and if it's something that we need to still discuss and just look into a little bit further, I'd like to see what we can do more about it.
With regard to Mr. Mordomi's comment and taking it in bite-sized chunks, to me, I look at the whole mobile issue as one issue. It's just different aspects of the same issue. So I'm of the opinion that we not take it in bite-sized chunks, but address it as a whole. These are just, you determine based on which mode of practice it is. I mean, I don't understand why we would go through all of the work of doing one and then go back and revisit it to do the other one.
Any other comments? I mean, you know, maybe a place to start, to your point, is putting a table together, taking what is current law and just you know, bullet point by bullet point so that we can address each bullet point. I also think we have to have some research on what can be done via regulation, what can be done via legislation, keeping in mind we're going into the second year of a 2-year, so it might not even be plausible to do anything via legislation until 2019. I kind of agree with you, Dr. Mack. I get that part of it. I also think you could get sucked into the weeds when you start talking about if you're going to have a office on wheels, what regulations pertain to that office, for, you know, ADA compliant. Do we do a radius of where you can have a mobile clinic, similar to what I think that was the Barbary board. What I find striking is that you look at the vet board, it seems like other consumer entities in California are way ahead of us when it comes to this issue, and I do think it's time for us to kind of look at it and figure out how do we catch up. I also, though, agree with the, you know, I go back to the pocket license and the house call and the concierge medicine, and I think that encompasses folks, even seniors or disabled, if their family or they want to pay for someone to come into their home. Maybe that's low-hanging fruit that we can take care of sooner rather than later. I don't know if anyone else has any comments.
So just to outline my thinking, there's a saying, you know, don't let the perfect be the enemy of the good. And it's not good meaning good enough for government work, but I always have in mind when I hear the perfect is the enemy of the good means to do good. And I see, you know, I see the house call issue a way for us to do good in a very needed situation. And we should think this through and make sure that trying to get a comprehensive or perfect solution for all the mobile clinic problems doesn't stop us from doing good in this particular area that we've identified a need. And it sounds like from the professor from Berkeley, it's an immediate, very critical need.
So I agree with your intent. That's one of the reasons that we're on this board, is for consumer protection and their advocacy. But as we look at this subject and we step back from it a little bit, one of the big reasons for us to address this was raised as access. But when we talk about access, I think, and I'm not an economics expert, okay, I only took Economics 101 when I was an undergrad, but I think it is a matter of supply and demand. So just because we as a board may create a new regulation doesn't mean that the care will be accessible to patients. Just because we may make changes to mobile clinic access does not necessitate that the access for the average consumer, even a rural market, will improve. So as an example, let's say that we open the floodgate, which is one of the comments you had made earlier, and so we get a flood of mobile clinics coming into California. There are optometrists in rural areas. They're very spaced out. They rely on patients driving for many miles to get to them. They have their patient base. If suddenly laws change, regulations change, and allow all these competitors to come in, there's a very high probability those doctors will go out of business. Therefore, the standard model of care will no longer exist. So I understand what you're saying about let's open it up so that there's easier access, but there's more to it than just what we can do as a board, I think. So some of the questions around VSP or those kind of things, I think are going to continue to be an opportunity. There's a reason why Vision to Learn hasn't expanded out into Reading so far, and it's because even for them, they have to watch where the demand really is. So I just want to caution us to not make rash decisions with really out understanding the big consequence.
But on that point, but to the point of allowing an optometrist who has a brick and mortar practice in Reading the ability to add another layer to his or her practice by being able to also offer in-home services, wouldn't that benefit their business? I think I look at it separate. I look at the mobile clinic separate from the licensure issue. So if I'm taking the mobile clinic part off, I'm looking at the licensure issue. If we gave more flexibility to current or future optometrists licensed in the state of California on where they can practice, wouldn't that maybe allow more access because they can go into someone's home in these rural communities? Or a question, with folks that are graduating from optometry schools, where are they practicing? Are they buying brick and mortar practices? Do you think that the future generations of optometrists are more adhered to having that flexibility to be able to practice wherever, as opposed to only being tied to a brick and mortar location? I don't know, do you have any, since you're the closest
The
one?
question for us is, what is it that we're trying to do? We've talked about access, we've talked about supply and demand. There's a reason that the for-profit entity has picked major cities. There is a reason that the nonprofits have picked major cities. What is it that we want to do for our consumers? That's the bottom line. And then from there, we can decide what steps to take.
And I think that goes back to what you said earlier. For me, it's access. I want a consumer to have multiple opportunities for access, whether it is to go into a brick and mortar practice, whether it's to have someone come to your home and conduct an exam, or if it's to have a mobile clinic available in your community, if that's the way. I think from a consumer lens, what is easiest for consumers? I guess that's how I'm looking at it. I don't know. I think it could be three different pots that we have to address.
Another comment, back to what Dr. Kawaguchi was saying, so you may eliminate some of that, and create more competition for those existing doctors. Again, that's not in the scope for consumers, but if it's not financially viable for a mobile company to go into that area, they're not going to go. So I think it would sort itself out in the long run. Whatever's going to move forward, that is the future. It's going to progress the way it's going to progress. I don't think the mobile.
But you can't progress right now because you can't have a for-profit mobile clinic in the state of California, correct?
Correct.
Is that correct? So the only mobile clinics you can have right now are nonprofit mobile clinics, correct? Or associated with a school.
Right.
Right?
But we're talking hypotheticals
Yeah,
here.
I agree with you. So I'm trying to I guess.
So I think increased accessibility, but maintaining standard of care. So our whole thing is we want more people in the state of California to be able to have access to eye care. But I think as a board, we have to see a way to ensure standard of care I think that's the most important. Because we could have a flood of mobile clinics come, but if they provide substandard care, then we're not doing the consumers any good.
Okay, so I have a follow-up comment about access. I question whether or not there's an access issue in total for California. I do believe that there's an access issue for free philanthropic care. So we know that exists because we know that there are kids slipping through the cracks. So to the point that has been made by our panel, clarity is very important to them. Their investors are going to be more hesitant if there is ambiguity, which some people may say there is currently. So as opposed to approaching it from a really global standpoint of us trying to fix the world, it could be that we need to just offer better clarity so that these philanthropic organizations have an easier time ensuring that they can continue to grow and expand. Because I don't think anybody's proven that there's an access issue in total in California. Is there any data that supports that?
trying to figure out how I want to say this. I guess access, especially in underserved areas, but there's definitely that subpopulation that has Medi-Cal. So we're talking about a lot of kids that may have Medi-Cal, but their parents might not be able to take them to the eye doctor because of work obligations, or they physically can't transport their kids unless they have to take a bus. So I think if we did have mobile clinics, and we can't do anything about Medi-Cal billing, but if mobile clinics could bill Medi-Cal or Medicare, then it would be more financially viable for them. So we could always make the suggestion, I guess.
You can put anything in legislation, you just have to get through the process.
But then that would actually increase care to certain populations that may not go. But they do have insurance of some sort. Not just
So to play devil's advocate,
Then I have a confounding issue.
yeah, we have the confounding issue in the state of California of there not being enough practitioners that are accepting Medi-Cal.
Right.
Correct. So we could, again, make changes to mobile or in-home access, but if practitioners are still unwilling to accept Medi-Cal, then we're still not improving access.
But I think if you don't have a brick and mortar, if you don't have the expenses of a brick and mortar, maybe more people, this is just, perhaps more people might be more open to opening or starting mobile clinics that would then go to this more underserved areas that do have Medicare and Medi-Cal. That's just.
Right, again, so hypothetical. So what I was hearing from our panel, though, is to establish and run a mobile clinic, it is not inexpensive. It's not an inexpensive entity to do it well. So it could hypothetically increase access, but it also may not.
I guess my question to 2020 is that you did mention that your company does bill Medicaid.
Yes, yeah. So, so two things. So one, Member Kawaguchi. First off, very respectfully, there is a latent access issue across the country. 65% of our first-time patients haven't had an exam in 2 or more years. We aren't just providing access to people who might go to a brick and mortar. We are educating patients. We're providing an opportunity for multiple channels for care. And so because of that, those people then engage in their care. People who are diabetics, who are historically just terrible at engaging in their health, then see us and then go back and see their primary care provider. And so I don't have hard data on it, but outside of knowing that 65% of our first-time patients haven't had an exam in 2 or more years, which leads me to believe that a lot more people are getting exams when there's availability. And so downstream, what that translates to is that optometrist in a county that is otherwise, doesn't have enough individuals to see the optometrist, that optometrist can then have a mobile unit and go to other areas nearby and actually grow their practice because they're coming to those people. The number of people who aren't driving 40 minutes to go see them, they now go into that community and now they see everyone. And so it's really growing the market for care. And then the downstream effect behind that is that it actually increases the number of jobs for locally trained independent optometrists because more people are getting eye exams. And that's just better overall, right? On the Medicaid portion or Medi-Cal for California, yes. So we're in network with Medicaid in all 3 of the states that we operate in.
I have a question for you on your 65%. How do you know why those people haven't been to an optometrist?
So in the patient feedback that we receive, so every patient receives an email or a text message to elicit feedback. See about a 20 to 30% response rate, and very frequently convenience is cited as one of the key reasons. We don't know, traditionally, what we know anecdotally is that these are people who have 20/20 vision. but are going because they already have vision insurance and it's there, so why not go? Or because they heard great things, so they want to check it out. So it's a fair point. I don't think we can fully specify why those people come.
Damien Carroll, Vision to Learn. So I mentioned as part of our presentation that on average the schools we visit have approximately 75% free and reduced lunch program. Now the threshold to qualify for that program is approximately the same as to qualify for Medi-Cal. So this is a rough proxy that about 3 out of the 4 kids that we see are at least eligible for Medi-Cal. So respectfully, it isn't that the service that we're offering is free of charge. These are students who have access to insurance, but they're not using that coverage to get access to the exams and classes. What's connecting them is bringing the service to them at the school. We have a number of optometrists who work at a brick and mortar practice and work a couple of days a week on our clinics. So they're also expanding their practices, expanding their capacity to serve by bringing their services out to, in our case, students who otherwise would not be accessing optometric care. So we very much believe that there is additional capacity within the optometric community to serve more people in the state, to find ways to access them, and that mobile care is a really great way to do that. And again, speaking to the Medi-Cal piece of that, we all know the Medi-Cal rates are comparatively low. That's one reason why not a lot of practitioners are necessarily on Medi-Cal. This is another access issue in a lot of the communities that we serve. If a parent is calling through the list that comes up on Google, the first 3 or 4 they call might say, we don't accept Medi-Cal. They may get frustrated. There may not be a practitioner in the area that accepts Medi-Cal, or easy to get an appointment there in a couple of weeks instead of a few months. Vision to Learn and other nonprofit programs that combine private philanthropy with the sustainability in LA County for now, and hopefully in some way to expand this throughout the state of Medi-Cal. This is a way to create a solution to this problem. It allows some of our optometrists who may not accept Medi-Cal in their regular practice to serve Medi-Cal patients through Vision to Learn, and if there is any shortage there, it's supplemented by the private donations that we're able to leverage, in part by talking about the sustainability of the program. A lot of foundations want to know, we'll give you some funding today, but 3 years from now, 4 years from now, we don't want to continually be on the hook. Being able to access the currently existing public dollars in terms of Medi-Cal reimbursement is a good way to reassure these foundations and other donors that this is a program that has other resources going forward, so that the private part of it can shrink to a more manageable level.
Our legal counsel has asked for the floor, but can I let them go first? Okay, Dr. Perez.
I'm going to go on for a while, probably. A quick question, though, Damien, with Vision to Learn. The optometrists that do work for you, are they employed by Vision to Learn when they're working for you?
We contract our optometrists, so they're 1099.
Where's that fit in the law, Jessica? No, I'm just wondering, because this also goes along with one of my...
Just to add, we prevent blindness. Our optometrists are all currently employees,
Okay.
W-2 employees, but we're also looking at utilizing a 1099 model as well.
I don't know. I know that what's in the regs pretty much specifies that an optometrist can either work for another optometrist, a licensed healthcare plan, or an ophthalmologist, which I think is extremely restrictive on that. I'd like to see that expanded too. But here's some of my thoughts on what we've discussed so far. To Mr. Mordami's point regarding home health care, I think we're all sort of thinking in terms of glasses with this. You might have somebody that you're treating for glaucoma, or their physician knows they have glaucoma and they are homebound, and you're going to send somebody over there who's going to check their pressure and modify their medication. In the world that I work in nursing homes, most of our patients are unable to perform visual fields either cognitively or physically. Doing an OCT, which we could get a portable OCT, again, the cognitive and physical abilities are just not there. So there's sort of seat of your pants treatment in these cases, but for folks who are homebound, you're probably not going to be doing those tests on them anyway, and they still need care. And I think if we're doing this at least under a physician's order, as Dr. Wong brought up, I think we're covering ourselves. So your personal physician wants me to come to your house and see you, just in order. Request eye health and vision consult with follow-up treatment as indicated. That meets all the requirements of Medi-Cal and Medicare.
Does it meet the requirements of our rules?
No, but that's why we have to change it, and that's why we have to consider changing something like that. As far as folks working in mobile type setups, contrary to Dr. Kawaguchi's point, I think competition is great. I know that in my world where I'm working, we have competitors, and the only way that we're continuing to grow is by upping our services and providing faster care, more frequent care, and better options for the facilities that we serve and their residents. So I think that providing more competition is a much better thing. When you're dealing with school districts, I think if you have contracts with the school districts, and as I think it was you, Seth, mentioned multi-year contracts. Was that you?
No, but we do in some cases.
But having a multi-year contract where you know at least that entity is going to be there for more than one day and then never see them again. If you're dealing with folks maybe with a large migrant population, say you're dealing with a strawberry grower out in Watsonville, you have a contract with the grower so he or she can provide services to their employees and their employees' families. And as long as there's a contractual agreement in place, there's some legal documentation of what's going on. If the board has licensure for this type of mobile setup, and possibly a requirement that there is a board notification when you are going to be at a mobile type facility, like you're going to go to Cisco, you're going to be at a strawberry grower, wherever you're going to be. My biggest fear, and I think everybody's concern, would be you pull up outside a mall and you put out your shingle and say eye exams today, $20, and nobody knows who you are or where you're going. So we're going to have to put some structural precautions in place to prevent that from occurring. But I really think we need to expand this. And regarding having a non-optometrist or a non-ophthalmologist hiring an OD, if we do have somebody who's out in Alpine County has 0 optometrists. There is no optometrist licensed in Alpine County. But there are several physicians in Alpine County and a health clinic. There's no reason that a physician, any physician or an osteopath, shouldn't be able to hire an OD and have that OD provide vision care services. I mean, the OD might not want to have his or her own practice, but they might want to be part of a clinic that exists in that place. And we can't do that now. And I think the more we open up this law with guidance and protection, I think we can offer consumers a whole lot more options for obtaining care.
Before Kurt talks, can I say something? Because I think I can predict what Kurt's going to say. So speaking for myself, and I'm sure a majority of the board, I don't think this board cares about competition. That we're not, we don't want to be market players. And that our concerns are the two items that Member Wang mentioned. That is standard of care and access to care. Whether one segment of the market does better or worse, I think it's none of our concern.
Make sure that all comments are exhausted before I begin, because I have a 6-pronged comment.
Oh, well, then I have another comment. Yeah. So, as I'm processing this, I'm trying to figure out, we're talking about, and I'm going back to the for lack of a better term, concierge medicine. I guess, what's the difference then between that and the ease of doing an online refraction on your cell phone? I mean, if we are going to, in my opinion, I would rather make it easier for consumers to have access to a licensed optometrist who is going to be in the room, whether it's in a home, a nursing home, whatever, having an exam, having a conversation. I think they're going to pick up more just by having that personal interaction than me then saying, great, I don't have time to go to an optometrist. You know what, I'm going to pull up the app. I just need to get my glasses and I'm going to do it that way. And so how do we weigh that with, I just want to, I don't know what the answer is, but as we're talking, I'm thinking to myself, well, it's going to be this difficult for me, to fit this into my schedule, even though I do fit it in my schedule. But for other folks, it's just going to cause people to go to using their cell phones. And we know that technology is already, it's here. It's already in the state. So I don't know where that fits, but that's just one of the ideas that came to my head as we were having this discussion.
And that, Ms. Michelin, was my confounding issue.
And not only that, I could be Joe the physician, Joe the ophthalmologist, who hires a technician to go out in the Walmart parking lot and set up my little camera system and say, vision refractions today, $10.
So, I mean, if it's consumer protection, then allowing more options and different models for a consumer to access the care, I think that's something that we have to consider.
Mr. Hepler?
Thank you, members. Again, I'm not a policy person. The policy considerations and policy determinations are left to the board and its members. But let me just clarify. I must echo what Ms. Burke said, is that the legislature has spoken and told the board whenever it exercises licensing, disciplinary, and regulatory oversight functions, consumer protection is its paramount priority. So as we go through and we deliberate, I would just ask that everybody make sure that they have that lens in place, which is consumer protection. The second thing, I would just kind of echo what Ms. Michelin said, and that I don't want to confuse or conflate two issues, that mobile clinics or mobile care is not the same model as house calls. I think they're radically different. And the reason I say that is as former counsel to the medical board, the optometry board has a very, very, very comprehensive licensing scheme. It's first you get a license, then you get a statement of licensure. You could have a branch office licensure, and then if you practice as a corporation, you could have a fictitious name permit. So there's four levels of intrusion, if you will, into the regulatory or licensing scheme. And the reason I say that is I would ask the board to consider as it goes forward. The Little Hoover Commission of the state of California has recently tackled occupational licensing. And one of the things that they have suggested is perhaps not all licensing requirements are essential in the marketplace, and that's for personal licenses and other licenses. But I think there could be a rough analog to what we're talking about here as to mobile clinics. So I would ask the board to consider that. In my almost 15 years of being a lawyer for the state, I just want to caution the board, the reimbursement issue of Medi-Cal or Medicaid or whatever is not generally a function of the licensing board. That is generally a function, if work wants to proceed in that direction, the industry, the trade association, the licensees themselves, whatever, generally tackle the issue of reimbursement. Because the issue of reimbursement does not necessarily square well with consumer protection. And I just want to echo the final thing I was saying. I think U.S. Supreme Court in the recent, not so recent now, but in the relatively recent North Carolina decision has sort of dictated that, competition, promoting competition is kind of good. Those anti-competitive things that would restrict competition in the economic marketplace does potentially, without some safeguards, imperil the board going forward. And panel, if I could just take some liberty here, I just want to confirm, when questions were asked about the expansion of services throughout the state, is it a fair assessment today from my perspective, is keeping notes, is the primary impediment, I don't want to say barrier, primary impediment to some of your expansion throughout some of the underserved geographical areas. And I used to work for an assemblyman that had Chico north to the Oregon border, and I think if we called the role of optometrists in that area, it would take like 35 seconds. So, but I might understand that most of the impediment is in fact economic, resource allocation, risk aversion, and perhaps not government regulation that's the barrier. Would that be a fair assessment?
Actually, I can speak a little bit about that. I hope I'm on the right track, but I have heard of doctors that are afraid to go to patients' house because of the board, honestly. They're like, oh, no, I don't think I can do that. That's just my experience, though.
Yeah, and in the case of for-profit practitioners in mobile practices, the regulation is a clear impediment, obviously, and so because of that, we can't even contemplate service underserved areas. And I can say in the case of Illinois and actually Georgia, we have multiple clients that are 100+ mile drives away. Remote communities, no other in-network providers. So.
Yeah, I understand your predicament, sir. I was just saying you have a clear regulatory / legislatory bar. I was more to the other folks. So thank you. Thank you, Ms. President.
You're welcome. Okay, next steps.
One more question, one more quick comment. Very quick. You don't need to have a $100,000 plus mobile entity to do mobile vision care. The way my group works, we have, all of our doctors have $20,000 worth of miniaturized, computerized portable equipment, and we can set up anywhere within the confines of a nursing facility and provide care. So you can do all this with about $20,000, get everything that you need to do a comprehensive exam, which is right on par with what you're going to get in a brick and mortar office. So.
And I could see, private practitioners being able to put together a small amount of capital to go to to a patient's house, for a homebound senior. I guess one other comment I would say in terms of why don't we just let's all get home eye exams, or why not, when you're at the nursing facility, Dr. Turetsky, why not just examine the staff as well? And I think what I would say, in my opinion, is when you're in a home situation, the optometrist will probably, hopefully agree with this, is that, it's not ideal exam room. The lighting is not perfect. The, distances that you're working at are not perfect. So it is a compromise. And that's why we were very strict in that we made it in our program. We said, no, if you can go out and get an eye exam, we really want you to go out and get an eye examination, because when I look at somebody in our practice at Berkeley Optometry, the lighting is good. I have, the technology that's available. And when I'm in home, I can do a good exam. It's just not optimal, in my opinion.
That's why we're seeing folks where we have a request from a physician
Right.
to see these folks.
Right.
Because to your point, seeing the folks in the staff,
right.
if they want to be seen, they can go to our brick and mortar office.
Yeah, and they'd probably be better served because of the more, the better setup.
You're assuming that every single optometrist office in the state of California is adhering to that same standard. With the lighting, with the optimal conditions. And I guess I look at it again from a consumer protection standpoint. And if I'm looking at a consumer and the choice is never seeing or getting a comprehensive eye exam, or getting a eye exam off of a cell phone, or having the capability to have someone come to my home and fit my schedule so I at least get that exam, and maybe that optometrist, because I'm in the same room with that person, is going to say, hey, I saw that you've got some issues. I really think you need to come either to my office, or I'm going to refer you to an optometrist who does have a brick and mortar, because they have the capability of the office to do that. I think that's more in the roads of consumer protection than saying, you should go see to a brick and mortar and then I never go. Because I think that's what we're seeing both among children and among parents, because children aren't getting comprehensive eye exams at the right numbers because why? Their parents aren't taking them, which means the parents aren't getting comprehensive eye exams. So I disagree with you a little bit because I think that we have to look at it again. California is diverse. It's huge. There's all kinds of different populations. Someone mentioned that certain folks won't cross a bridge because it's not in their community. How do we make sure that, at least in my opinion, a consumer is at least establishing a relationship with someone in that medical profession?
So I think just to reiterate what I was saying earlier, I think for the board, at least from our perspective, is that we just need to ensure quality of care. So if it's going to be mobile at home, like in-home visits, concierge service, or mobile clinic vans, we as a board need to ensure the health and safety and maintaining quality of care.
So how would kick off your next steps?
Because you'll read what I'm going to say because you did it so well with him. I know you're going to do it. Go.
That's where you're going. It's like, what are the next
Yeah,
steps?
exactly.
So let me suggest at least one next step that I want.
Okay. Turn your mic.
Next steps that I want, and that is, I appreciate the kind of spectrum of choices that I and my fellow member down 2 seats down have, but as a list of options, I'd like one option to be a targeted response to the house call issue, be it statutory, regulatory, advisory, or educational. And of course, we'd have the kind of larger response too, but I'd like to see that kind of laid out so we can make a strategic decision which way we want to go. As a personal request, to the extent our legal counsel has time, I'd like to, for me or maybe the board, a little bit of a better understanding about the branch office license and why the heck it's there. Since 1934 or something like that. It seems, I mean, I can conjure up some consumer protection issues, but from a kind of totally cynical perspective, I can see that, hey, this is a way we can limit optometrists to 2 offices and squelch their ability to grow and whatnot. So it's very suspicious to me, and I'd like to know the origin of that. And last, and I'll try to shut up after this, I really compliment this board for all the thoughtful discussion and even those comments in opposition to the kind of the crazy ideas that I have. This reminds me of the debate that the taxi cabs have against Uber, right? And I remember the taxi cabs were saying, well, all these Uber drivers, you don't know who they are, and it's going to be totally unsafe, right? And so Uber's had some responses to that by getting insurance and whatnot. I had a conversation just this weekend with my parents who are, in their 80s and 90s, and they're still driving, which kind of scares me a little bit. And I said, it's so cheap now to get a car to take you to grocery shopping and all that. And their response to me is, well, but those taxi cabs, they're so expensive. And I tell them, well, no, there's this thing called Uber and Lyft, and you can put it on your cell phone. And look, it's only $5 to the grocery store as opposed to $10 with a taxi cab. So, this issue reminds me of that issue.
It looks like you're about to say something. Mike, your mic.
At the risk of throwing my colleague, outgoing counsel and incoming counsel can certainly work, if you direct us so, can certainly work on Mr. Morodomi's request.
If I can make a suggestion, what we could do is punt this to the Ledge Reg Committee.
Where I was going to go.
That's why I was rolling my eyes.
New
Okay.
Ledge Reg.
And possibly vet some of these things, and so that by the time we have our next board meeting, we can have this on the agenda and have further discussion. But at least it's an opportunity for legal counsel to get us some answers. B, it's another opportunity for public input as we're going through this process. And then C, we can bring it before the full board and have the discussion again. And maybe divide it up. Maybe we look at the low-hanging fruit. Maybe some of the issues Mr. Mordon was talking about, low-hanging, we can have a timeline on how we can accomplish those goals and then take some of the bigger pieces at a later date.
Can we put a D in there? And the D would be potential mobile optometric facilities work group or groups based on what Ledge Reg considers.
Well, what we could do is divide out the different,
prioritize.
different
Exactly.
factions, and then come back to the board and then assign work groups.
Ms. Burke?
That was my question. Is it a work group or is it
We'd like the
legislative?
committee determine whether there needs to be some task force work to be done in short little, it's up to Ledge Reg.
I'd like to counter that and suggest a work group and then have them move
Okay.
on to the legislative committee.
Okay. Before we take,
Oh, so when you're saying work group, are you saying two or more than two?
More than two.
Okay.
okay. So potentially a committee in it of itself versus a work group, okay. For us to, any public comment thus far, we haven't made a motion yet, we're going to go there next about next steps, but I just wanted to give you one more chance before we establish the motions here as to next actions and steps. You're good with the direction we're about to go, okay. So, from board members, do I have a motion to put on the floor for any specific next steps? And I know, here we go, Kurt, Mr. Hepler.
Mine is
So I'm
not
running.
on the merits, I just want to inquire, the work group concept was broached. Going forward, the question would be, would that be a work group of just board members or more than board members?
We haven't even gotten there because there's nothing on the floor yet
Great.
to discuss. So.
I'd like to
Go on.
move that we create a work group to study this issue that includes external community members as well.
Okay. Comment. Well, first, do I have a second? Okay, I have a second from Ms. Garcia, and now discussion.
So I have a
Mr.
question,
Mordon.
maybe this is to our legal counsel or maybe the maker of the motion. So let's say we have a work group of 2 board members and 2 external, or 3 external members. How does that kind of issue then percolate up to the Ledge Reg committee? What if the 3 external members vote against the 2 board members? Does it, how
It
did
really, Mr. Mordon, it really depends on the charge that sort of results from this discussion. If in fact it's an appointment of some number of composition, which is gonna be 2 of those and 3 of those and whatever, and then if their direction is do the heavy lifting, bubble that up to the committee, who then bubble that up to the board, it can go that way. It really depends on what charge is given to the group.
certainly agree that the work group should get input from external members, certainly.
So are we saying we're gonna specify what external stakeholders are on the work group, or are we gonna open it up to anyone who would like to be, I mean, cause I don't know, I'm comfortable saying only these stakeholders can participate. I mean, I'm thinking of when we did Children's Vision, we had a stakeholders meeting and we sent out invitations far and wide to anyone we could think of, and we hosted these around the state. Now, if that's something, but it was a stakeholders meeting, interested stakeholders meeting, which, you know, we were collecting information, we were getting input, you know, so I just question what exactly framework are we putting it in?
One is the traditional, which would be a traditional work group, 2 board members that then get together to determine what types of meetings are needed, whether it is a stakeholder meeting, whether it is to speak with Ledge Reg, what have you. The other I'm hearing is more along the lines of an advisory group, and that tends to be, Kurt, correct me if I'm wrong, doesn't that have to be appointed through a legislative body?
No, I think the board can, or you can compose the work group. My concern is though, obviously if we have more than 2 members, we're in the realm of
Right.
open and notice, so I think we've already crossed that threshold. I think from my perspective, the issue is what do you want this group to do? And by that I mean, what do you want them to do and who's gonna be at the party? Because sometimes, as Ms. Michelin correctly pointed out, sometimes you have a stakeholders meeting or an interested parties meeting, you have maybe 1 board member or sometimes even 0 board members, and then you float whatever idea you wanna float out there, publicly noticed, and then all the board staff does is say, listen, we're contemplating this issue, we're not gonna make any decisions, we're not gonna act like little sponges, soak up all the information, distill that down, and then we can take it to wherever they wanna go, the committee, the board itself, whatever. So, not on the merits, I'm just asking as the board goes forward, think about what the task is, and who's gonna do it, and then what the output is, and where that's gonna go.
And thank you for that, because I do think, we have a Ledge Reg committee. What I would say is if there are people who are passionate about this issue that want to be on the Ledge Reg committee, they can certainly approach you and you can put them on the committee, because you can have up to 6, right, 5 people on the committee, and I don't know who those folks are, because I don't want to duplicate staff time either. I mean, I think having another work group that leads into the Ledge Reg, I maybe it goes to the Ledge Reg, and then then that pushes a work group. So, and I'm just saying, to me, a Ledge Reg committee will be publicly noticed, public comment, folks can come and give their input. Hopefully we could even do it at a facility that could be webcasted, so board members who aren't physically there can watch it and hear what's going on. But I think that is less duplicative. I'm all for work groups, but I think we need to figure out what the pieces are first and then do a work group.
Excuse me, and that is the reason I'm suggesting the work group rather than the legislative committee. One, the legislative committee already has a very full agenda. We've spent more than 4 or 5 hours on this issue today, and we still don't really have our arms around it. There's still a lot of data that needs to be collected and a lot of external perspective that needs to be incorporated. My vision is that we'd have a work group study this issue intimately and offer suggestions or recommendations on where it should go next. My thinking is it probably is going to be a legislative item, which is why I said, and then refer it to the legislative committee. But it's big. This issue is huge. And relegating it to the legislative committee, I think it's too big for that.
Well, but then how is it not too big for a work group? I mean, I would argue that the Ledge Reg committee, at least myself, Lillian, and Marie, we've already listened to a lot of testimony. We have kind of a basis of kind of what we've already discussed. We've brought it forward to the board. I guess I get what because I absolutely agree with you. It's a huge issue. I personally see it more coming down from a staff perspective of saying, here are all the different components, and then we just kind of weed through it, and I'm seeing a chart saying, well, this is a regulation we could do, this is legislation, this is low-hanging fruit, this is something that's going to take a lot more input, and that's when you push it back to the board and say, okay, who wants to be on what part of that work group? Because I just don't want to see us, I think we've been doing this for over a year. We keep talking about mobile clinics. This is the first time we've had this discussion as a board. I don't want to punt it to a work group and then it's another 6 months to 9 months before we ever get any kind of resolution.
I wouldn't restrict myself to the timeline given the importance of the issue. I think it's along the same realms of the vision work group. This is going to require input from community groups across the state.
So
I lean toward Member Burke's motion. My fear is by sending it to the Ledge Reg Committee, we're just adding an additional step to send to the Ledge Reg to send it to a work group. If we as a board know we want to send to a work group, we could do it today. Now, I appreciate your concern that this issue is maybe too large for two-person or even a three-person work group. I get it, and the need to kind of maybe split this up. Could the work group, for starters, be not you guys do everything work group, but a kind of a work group that's the quarterback? They'll look at the issue, maybe work with staff and say, oh, okay, there are these issues. We can't do this all. Let's ask to farm it, ask the board or ask the Ledge Reg Committee to farm it out and act as kind of the first decision maker as to kind of identifying the issues and then seeking additional board resources or board members. Just an idea.
So am I hearing that potentially the work group, Ms. Burke, could be the framers to come together to suggest here are some list of priorities, potential timeline. Now we see this needing a larger body to address. This we can delegate off to staff. This, it's really framing the, is that what I'm hearing you
yes.
say? Okay. And Member Morodomi, I think I'm hearing the same thing from you. But other comments, please? Other comments? Dr. Calgucci.
So this is a big, big subject. I think the benefits of a work group is that it can be relatively nimble and fast. The work group will also, I think, be charged with making decisions on whether they need to bubble things to the Ledge Committee, or if it's a larger item that the entire board needs to hear, bubbling it to the entire board. And I would trust that our president is going to partner with that work group to ensure that those kind of decisions are made in the best interest of the consumer.
You have my commitment. That I will do. So we have a motion on the floor, and so I will ask our secretary to repeat the motion and any comments from the public before we take a vote? Okay.
I just want to go back to, I get the two board members. Who else is going to be, is it open to anyone in the state? Are we going to do full outreach to folks to be part of the work group? Who's going to be part of the work group from a stakeholder perspective?
The work group would frame the path forward, which will include stakeholder meetings, etc. It's a little premature to start identifying who's sitting on a much larger committee when we do not have an outline of what this issue will take in order to start moving things forward. So they're to frame out first, what are the issues, what kind of steps, what kind of people and involvement, and to come up with that one sentence charter that relates to consumer protection of what our goals are.
And then the work group would then bring that back to the board?
Bring that back to Ledge Reg and the board. Likely because the Ledge
So
Reg
it has to
reports
go, so
back
we're
to the
going from a
board.
work group to Ledge Reg to the board before we really take any action?
No, not necessarily. Dr. Calgucci, do you want to comment?
So just like with our work group for Children's Vision, there were times where we would report to a committee because it was appropriate, or there were times where we would just bring back reports to the entire board. So that's partly the discretion and recommendations of the work group in partnership with our president to decide where it's going to fall on who to bring it back to. Does it go to the Ledge Reg Committee because that makes the most sense and then comes to the whole board, or does it go directly to the whole board because of what context or content that they have?
Okay, I just want to make sure that it's an open process and any stakeholder who wants to participate will be able to participate. And I think part of what got into, and correct me if I'm wrong, Jessica, last time we had this bill, certain stakeholders felt like their voice wasn't heard. And so what I'm hearing, and maybe I'm hearing incorrectly, I just want to make sure if it goes to a work group and the work group has a meeting, we're going to do a huge outreach. I still personally think you're duplicating things, because I think you have a leg committee that can do a lot of this work without having a work group. But, I think it's an extra step. I think it's an extra step for staff. They're going to have to prep work group materials for work group meetings and then do the same thing for a leg committee meeting. I think you're just duplicating the work. I just go back to, if there are members who are passionate about the issue, put them on the leg committee. Let the leg committee have a standalone meeting pertaining to the mobile clinic issue. But that's just my comment. But I will reinstate the motion. And the motion is that we take the mobile clinic issue and we, the board president, appoint a work group of 2 board members to meet and frame out the issue pertaining to what steps the board can and cannot do pertaining to the mobile clinic issue. Is there a second?
I second
Oh, that's the
It
motion.
was.
No, who made
You
the
were-
motion? I'm just
I made the
repeating it.
motion. Yeah,
So, opening up for public comment. Board?
So
Oh,
I would just say, yeah, so I would just say that in sort of the vast majority of other states that don't have that don't regulate mobile optometry, there hasn't been a floodgates issue of all these low quality mobile optometry providers with lots of complaints to the regulatory committee. So I would kindly request and sort of have the board think what is going to be the most expeditious and manageable resolution of this issue, because as large of an issue as it is, it can also be a small issue in some ways if you think about the parallels with other states and kind of the uneventfulness of what the issue is elsewhere.
Ms. Berg?
Aye.
Hello. Was that an accurate restatement of your motion?
Yes.
Okay. So we have the motion, we have a second. Let's call for the vote.
Dr. Turetsky? Aye. Ms. Michelin abstain. Ms. Burke?
Aye.
Dr. Chawla? Not here. Ms. Garcia?
Aye.
Dr. Calducci?
Aye.
Dr. McIntyre? Mr. Moridami?
Aye.
Ms. Berber is absent. Dr. Wong?
Aye.
And Ms. Brandwein?
Aye.
Motion passes.
Thank you. At this time, we're to take a quick break, but I'd like to say, with respect to the mobile optometric facilities work group and who's on it, I'd like to table it until we discuss 9C when we come back at the appropriate time in our agenda, because then it may fit into place with how the committees are framing out. So with that, let's take a 10-minute break if we could, please, and we'll see you back shortly. Thank you. All right, we're reconvening following recess, and before we go into agenda item 9C, Dr. Turetsky has asked for the floor.
I would like to thank our executive officer, Jessica Sieferman, for getting all of these folks to attend.
Yes.
I was just talking to Jeremy from 2020, and he came out here on a one-day flight from Boston. I mean, you did a great job. So on behalf of myself and the board, thank you so much.
Thank you, yes, thank you. Okay, we're back. So, agenda item 9C that we're taking a little bit out of order because I wanted to discuss the process for committees, the draft assignments, if you will, and give you an opportunity to think about them overnight and then get back to me and the whole board tomorrow during the session when it appears on the agenda. I'm throwing this out for deliberation and for your consideration, my thoughts behind why I selected certain people for the draft. And sure, you can let me go person by person, and then you can hand them out, so then I can walk them through, and then they have something hard to look at. So first of all, guidance for the committees. We're going to ask that at your first meeting, you select a chair. Then you meet at least once before the next board meeting. Meet at least quarterly before each board meeting, and we're hoping to have meetings now on the same date, so that if we need to pull people together for a committee meeting, you're here, and to best use your time, we may have 2 committee meetings on that same day. We're thinking of piloting this to see how it goes, because we can always go back to the staggered way of all the different committees, but we thought it would help staff with the preparation, also keep all of us focused on our committee task work at the same time, because we're doing report outs at the board meetings, and it will help control the cost for the state. Additionally, I'd like the first meeting to be one where you set up what your deliverables would be and what you're targeting over the next year. So it's really to establish the group, set your targets, deliverables, who's the chair, and come up with the cadence that aligns with what we're proposing, which is the meet quarterly, a month before the meeting, and targeting the same day for multiple committee meetings. And Jessica will work on the exact schedule. So looking at what your skills, competencies, and experiences are through the lens of Sid Brandwein, and looking at your bios and working with you now, many of you for several years. Ms. Burke, for example, your strong legislative affairs, public relations, philanthropy, and communications expertise. The Leg and Reg Committee and Public Outreach, if you would consider those as your potential assignments. You can think about these, and if you want something different, just let me know, okay? Dr. Chawla's not here, but she brings tremendous experience and knowledge in healthcare corporations, integrated medical facilities, hospitals, and in general, the broader healthcare practice through her association and her corporate affiliation. So for her, looking at practice and education, outreach, and to bring the next steps and final steps for the foreign graduate work group, because they had a deliverable due back to the team. Ms. Garcia, your role in opticianry, education, credentialing, and your professional association leadership, if you would consider practice and education, consumer protection, and of course, you are the chair of the dispensing optician committee, okay? Dr. Kawaguchi, if you, when I look at you, I think business startup, single practitioner expertise, and providing that lens, as well as your expertise with large corporate business models and your passion for children. If you would think about Leg and Reg, consumer protection, and the Children's Vision Work Group. Dr. McIntyre, your multi-state experience, your expertise with underrepresented communities, and the fact that you have been a CEO and understand business operations, consumer protection, and public outreach. Ms. Michelin, extensive background in legislative affairs, communications, outreach, and public speaking. If you would consider Leg-Reg, outreach, public outreach, and Children's Vision. And the Children's Vision, it would be the work group. I should make that clear. Mr. Morodomi, our legal counsel, de facto, no, with expertise in contracts, risk mitigation, educational institutions, and enforcement. If you would consider practice in education and consumer protection, please. Ms. Berber isn't here, but with her background in law and government affairs, not-for-profits, serving underprivileged children, and in public policy, she would be thinking about, or is thinking about, leg-reg and public outreach. Dr. Turetsky, even though you have VP responsibilities, if I can indulge your expertise in senior health, mobile services, insurance, and business operations in leg and reg and practice and education. And last but not least, Dr. Wong, your standing as a university professor, your multi-state experience, and your expertise in group practices, if you would give consideration to practice and education, consumer affairs and protection, and the foreign graduate work group. Why I'm letting you mull on that, as you notice, there are 5 people on each work group, or each committee. We're looking at more people to serve as backups, or if someone needs to recuse themselves, we still have the number that we need in order to execute the business of the committee through a majority. Our schedules tend to be pretty busy with our day jobs too, and so you may miss a committee meeting now and then, you may need to. The business of the committee can continue to move forward with your excused absence and partner with your committee colleagues when you're available, when you return. So with that, we're going to table the committees, because then tomorrow in the session with the full board again for our quarterly meeting, we'll go through the committees as they appear on the sheet. And then I'll ask if you would like to state any comments in the public session, or if you would like to get a note over to Jessica regarding these proposed assignments, that would be terrific. And then also, now that we know that we have to be determined the mobile optometric facilities work group, which if you have an interest in serving on that, if that could go to Jessica too, please, then I may be able to announce that tomorrow as well. And if not, it'll be shortly thereafter if we do not have at least 2 members with interest. So now we have concluded 9C, because legal counsel, can they ask questions on this or not? Okay, nobody can hear you. I know.
So it's my understanding that you wanted to hand this out for informational and think on it. So if you want to entertain a few questions, that's fine, but I believe you want to have the bulk of the discussion tomorrow, correct?
I have a
Go ahead.
procedural question. There's 6 people on public outreach. Huh?
No,
Yeah.
that's a typo.
Oh, it is?
It was
Okay.
supposed to come out because she's already sitting on dispensing optician.
Who is? Oh, Ruby.
Ruby's coming out.
Oh, okay.
Sid?
Brian is-
One question, one comment. The concept of having the meetings on the same day, that's with the kind of premise that these are in-person meetings, or is
That's
that?
to be determined,
Okay.
because some committees, it's easier to me, if you're going to have public comment and a stakeholder meeting that day, then it would be best to have the committees present with the stakeholders. If it is to go through 15 applications that came in for practice and education, it's never just 15, it's more than that, you likely can do that over the phone. Some are conference calls. It really depends on what the agenda is, and that's why we're asking that you come up with your targets of your priorities and potential deliverables, so we can determine, is it best to have it in person? Can it be done on using the conference call system?
But if it's to be done in person, the idea is to have them on the same day so the staff doesn't have
And
to
so
jump
you
around.
are not
Because
jumping back and forth,
because there are so many
flying and
committee-
moving,
yeah.
because we have several committees and a lot of priorities this year as we're taking on mobile clinics, online refractions, some of the bigger issues.
Okay, all right. And the last comment is, my name doesn't have an A in it, it has another O in it, so.
Thank you. Any other procedural questions? Okay. Now we're ready to go to closed session, so we are letting the public know that we are shutting down the webcast for approximately, how long do you think? So approximately 20 to 30 minutes. Thank you.